Welcome to the coveted before lunch slot, Legal Insights. I know that's always popular. That could cover a broad universe of topics. I think what we've tried to do today is to limit the scope of what we're going to discuss. Each of us, there's 3 attorneys and 1 honorary JD up here today, Jay. But try to limit what we're talking about to some finite points, leave you with 1 or 2 takeaways. And we've kind of split this up to cover different facets of the vast legal universe. So I know we're going to talk about plans, we're going to talk about patients, talk about physicians, but hopefully keep this moving along and leave some time, 10 minutes or so at the end for some Q&A. And I know they'll run some mics out to you. So with that, let's launch right in. Jay, first slot is yours. Thank you.
So, thank you for that kind introduction, and I appreciate it. I am not an attorney. I'm that evil healthcare lobbyist that was talked about earlier in the day. So to take a little bit of the fear factor, I thought it would be interesting out of the lobbyist moniker here. I thought we'd talk a little bit about what we've been doing in the Direct Primary Care Coalition for the last 15 or so years. And I won't spend a lot of time on this slide because I think everybody who's been up here has had some version of saying they're preaching to the choir. But, these are the results of what we've been doing in the last 15 years. And we'll show a little bit of a transition here in a minute. But, the reality is here we are. If you look at the DPC mapper, which is, I think, a fairly authoritative source about where the practices are. I happen to believe Phil Eskew, who runs that site, is our general counsel, and he's also a DO, a practicing physician. I think these numbers are low. So to the degree that we know and we've interacted with people in the direct primary care world, these are practices that are either pure DPC practices, hybrid practices, or practices that are on-site clinics that are operating in the direct primary care model. And what that means is they're running in a monthly fee membership model for the most part. Some are other quarterly fees or in some cases, rare cases, annual fees. And it's completely outside of fee-for-service reimbursement. One of the things that we're proudest of is that we've been able to have great bipartisan support for this on the legislative side. So we'll talk a little bit about the legislative history in both the state and in the federal government, but people may or may not know that the words direct primary care were actually first written down in that, I'm sure that piece of legislation that's all hailed here in this room, the Affordable Care Act. And why did we put the language in the Affordable Care Act that basically says direct primary care is an advanced primary care model that operates in states that's based on a piece of legislation that was drafted in Washington State, that is. And here's why we did it, because there were these 2 ne'er-do-wells, one living in Seattle and one living in Wheeling, West Virginia. That's Garrison Bliss with the blue background and Vic Wood from Wheeling, West Virginia. And in 2006, Garrison and Vic had both started, what they weren't called direct primary care clinics, but they were direct primary care clinics. And these gentlemen both had insurance commissioners come and knock on their door and say, if you want to do this, you have to capitalize and you have to be an insurer because what you're doing is insurance. It's the business of insurance. So in 2006, West Virginia allowed one doctor, this guy, Vic Wood, to operate a direct primary care clinic in Wheeling, West Virginia, and made it illegal for anybody else to do it. And that stood for almost 10 years that way. In 2007, Garrison got together a bunch of people for his, the first stab at a scalable DPC that would offer services to unions and employers and other people outside of individuals. Garrison actually went to the state legislature and passed legislation to define DPC as a medical service regulated by the State Board of Medicine, like any other type of medical service that's performed by a doctor, and it's outside of the regulation. As long as you're following the rules that are in this bill, you're outside of state insurance regulation. And then Garrison kind of knocked on my door in Washington as the Affordable Care Act was actually getting ready to go to the House of Representatives and the floor of the House. And he said, well, we've got to do something to stop this Affordable Care Act. It's going to destroy what we're doing. And what we're doing is really good in Washington. Look at our results. We're saving employers up to 20% of the cost of care. We had data in 2008 from Boeing that showed those numbers. And those numbers have been pretty consistent over the years. So, I said, well, we're going to vote on it in a month. And I don't think there's really an opportunity to stop the Affordable Care Act. But what if we put a provision in the law that said and mind you, the law was designed to give every man, woman, and child a health insurance benefit, and that primary care was going to have to be delivered through health insurance. So we essentially created a carve-out that said if you have a direct primary care, the term of art was direct primary care medical home, that coexists with a qualified health plan, that the two together could meet the essential health benefits requirements. And that stands in the law today. So it's really the first place that these rules were defined and the term direct primary care was defined. And then what happened from there was quite interesting. States began implementing laws and regulations that would define things that are in the things that are in the ACA at the state level. And one of them was direct primary care. So we spent, the better part of a decade and a half going across the country and facilitating a lot of the people that are in this room. This was a grassroots movement, but we helped to sort of facilitate with the legal rationale. We had and still have at the Direct Primary Care Coalition model state legislation that said very simply, direct primary care is a medical service. It is outside of the purview of the State Insurance Commission, and it's regulated as a medical service. So DPC, not insurance. And you'll see in the purple, these are states that did not pass laws, but have very good state insurance commissioner or state health commission, health reform commission guidance that says just that. So they aren't codified in the law, but they are state regulation. So, as you can see, we've covered, most of the country right now. And some of these states that are still in gray, they don't have problems in the law, and some of them do. And, there's some non-enforcement going on. But it's been really important. And I think if you look at this, it really tracks the growth of the movement. So you can see that this growth of DPC practices over time sort of roughly correlates, as Zach mentioned in his presentation, to when the laws have been passed. And the laws, I think, have really done two things. One is they've clarified very importantly in state regulation that this is primary care like any other part of primary care. It's not subject to state insurance regulation. But frankly, it's also been a billboard that says, hey, our state is now open for business for direct primary care. Employers, are usually written into this so that employers can participate in these arrangements as long as there's no double dipping going on. In other words, the employer is paying the fee, the doctor's not charging the patient another fee. So there are some safeguards and patient protections in these laws that weren't there previously. I think by and large, they've really been a very, very good, introduction to getting DPC to grow. Since then, we still have some regulatory hurdles that are out there. We have, as everybody knows, there are some IRS regulations that make direct primary care incompatible with Hsas. We've been working on that, trying to get a bill passed that has a very large number attached to it, that would potentially, make those compatible. We were able to get regulations passed that will clear the way for HRAs and FSAs. We also have a problem where most DPC docs, as you're aware, have to opt out of Medicare to be able to do this. So we spent a number of years working with CMS on a demonstration project for the Center for Innovation that we kind of hoped would look like DPC. It came out looking like direct contracting, primary care first, and the ACO REACH program, which really isn't DPC, but it does move. It's an iterative move towards DPC, monthly fee-based care, mainly outside of fee-for-service. So it's a step in the right direction. I think Medicaid, state employees, the VA, and the other government healthcare sectors are another place we have to go. And I think we're going to talk in the next session about stuff that's happening in Texas. In-office dispensing and prescribing is another area where there's a lot of regulatory hurdles that we're working on very closely. And I hope you will all join us at the HINT Summit coming up in June. We're going to have a major announcement about how the Direct Primary Care Coalition is working to try to facilitate sort of a streamlining and a regular process where docs will be able to dispense meds or dispense meds directly to the patient through one source. And it's exciting because, again, we want this to be about primary care, but we want to innovate around other things. And innovation has been able to take off since we've been able to clear some of these regulatory hurdles. And I think we're going to talk a little bit now about some of those innovations and where we've gone beyond primary care and where we build to the next step.
Jay, can you give us a little insight? Are there what are the prospects of some of the federal level initiatives succeeding, or will it take a turnover in terms of control in Washington?
So that's a very good question. We have worked really hard to build bipartisan consensus around DPC. You can walk into a Democratic office or a Republican office, and by and large, you're going to get the answer, oh, direct primary care, that's great. That's an advanced payment model that CMS is looking at it. We want to do this. But as we all know, Democrats look at HSAs as a four-letter word. So when it gets put into the confines of legislation that's about HSAs and not legislation that's about getting better primary care for people with high deductible health plans, we've run into a buzzsaw, as you know, a number of times. We have gotten, I think, half the way there. We put legislation in the CARES Act that would have allowed initially DPC practices during the pandemic to have these regulations waived. And they wound up limiting it only to DPC practices that offer telehealth. So there is an exception for telehealth right now. We're planning to build on that. And I think, to be honest with you, it's been difficult to get the bigger, broader bill passed. I think there's a ton of consensus around, certainly in the Republican Party, there's a ton of consensus around doing this as a number one priority. I think it's easy to sell 20, 30, Democrats on this, in the House, and certainly 10, 15 in the Senate to get something across the finish line. We're going to have to deal with that score. And I think the approach that we're going to take is to broadly accept anything that's in this advanced primary high value care thing from these ridiculous and anachronistic tax regulations, so that there'd be broad sort of waiver authority to allow these practices to do what they can do, and not say that people that have a $13,000 deductible health plan tied to an HSA can't participate in DPC.
Fascinating. Thank you. Cori, on to you. I'm going to pivot the focus a bit. I think you're talking about legal insights as they relate to plans, right?
Thank you so much. Thank you for having me. Jay and Keith, thanks for growing what you have built here. It's fabulous to be back. I was at the first conference and it looks nothing like today, so congratulations on that. For those of you that saw me pre-COVID, I had obviously short hair. I didn't even recognize my picture on the screen and a different name. So during COVID, I got married and my booster consisted of going from 1 child to 6. So if there is a DPC mental health provider in the audience, I would like to buy you dinner. I need to give a little bit of a background about me so that you understand why I have such a mixed bag of conversation pieces in my slides. So I cut my teeth at the TPA level. I was the chief operating officer and general counsel for a large TPA, EBMS, headquartered in Montana. Was with them for about 10 years. That's where I learned all things self-funding. I started with them, you'll appreciate this, when HIPAA was the pain in our side. And I grew within that organization and fell in love with self-funding. I'm a huge proponent. And then obviously all the things that come from that we're here talking about today. I left EBMS about 10 years ago and started CMC Consulting, which is a DBA of Fiduciary Risk Management. So it's a boutique consulting legal firm. My clients are self-funded health plans and TPAs across the country, and we do all things for them. And then out of a need in 2017, I started VezaHealth. I had a client come to me and say, I would appreciate it if you could help us find a remote second opinion program that we can embed into our health plan. So I went out and I scoured what was available, and I looked at the big name houses for their second opinion programs. I looked at Mayo's, I looked at Cleveland's. And when I was all done, I went back to my client with the results and I said, here's what is out there. And I would like you to take a chance on me. I'm going to start my own because I'm not happy with what's available. It puts the onus on the patient to do everything, and you're stuck with a second opinion within those walls. And so I went to a friend of mine, Dr. Marty McCary. I said, will you help me go find doctors within the U.S. that we can partner with for delivering remote second opinions? And I really thought it was going to be just second opinions, and I thought it was going to be primarily ortho. And you're going to see from a slide that I have that it is not that. I have a hard time describing as each continuing month and year passes exactly what it is, but it is a high-touch concierge program that health plans put into their plan and provide to their members for free, that is literally saving millions of dollars and saving lives with every human being that we touch. So with that, I will start with some slides. So just to remind us why we're here, this is what is on my desk. I have a $15 million 2-month stay, actually here in Texas, in Dallas actually. I was hoping that I was going to be able to take this trip and show up on their doorstep with a news station to talk about this particular claim. Unfortunately, it has been pulled into an arbitration situation because it's supposed to be in-network, and the in-network contract between the carrier and the provider requires mandatory arbitration. There are a number of entities that have been brought into this suit. There are a number of contracts that are at issue in this dispute, and it will be interesting to see at the end of the day if there is even a contract. So that is ongoing, and unfortunately, I could not show up with my news station. There's the $5 million inpatient COVID claim of a deceased person, $975,000 per infusion, and the gentleman was to get the infusions every 6 weeks. This was an in-network claim. The top 3 were in-network claims. I negotiated the second one down significantly, saved millions. Negotiated the third one down, saved millions. And I had a client come to me in Minneapolis. They had a $5.5 million laser on an infant that had been inpatient during the whole COVID period. And the patient was actually eligible and should have been on Medicaid. And instead of anybody knowing what was the right thing to do in that scenario, everybody just did status quo, and the employer got a $5.5 million laser for the baby. Had a client come to me saying, is it odd that we received a $350,000 laser on a deceased member? It's just how crazy it is out there. And then this last one is something that's sitting on my desk. It's not necessarily public information, and the attorney for this facility in Wisconsin probably wouldn't like me to share this information. But as most of you may know, nonprofit hospitals have to have, by law, financial assistance policies in place to maintain their nonprofit status. Many of them fail to use them appropriately. Many of them are starting to get cited for not using them. And one creative approach from a Wisconsin hospital has been to say that all the claims that are outside of their ER room are considered not medically necessary. All their surgeries are elective now. They're not medically necessary, and therefore patients don't qualify for the financial assistance policy, and they're not going to reduce those balance bills accordingly.
That's crazy.
Yeah. So of course my next email to them was, well, if it's not medically necessary, it's not covered. So good luck chasing every single patient that you have. This is going to be an ongoing story because right now it's an email spat between some lawyers. This is kind of the toxicity of inappropriate healthcare, right? We have 12 million patients annually that are misdiagnosed, 7.5 unnecessary procedures performed annually, 8.9 unnecessary hospital stays, 1 in 3 malpractice cases are due to a misdiagnosis. And just recently, I'm a Gonzaga Law School graduate. A friend of mine that I graduated with was involved in this case. Providence on the West Coast has settled for $22.7 million a case that's only related to Medicaid and Medicare claims, very small payer in their book, only related to neurosurgery claims, and they were all medically inappropriate. They were just churning people in and out, operating on their brains. Ironically, Providence is also one of the hospitals that is being investigated right now and cited for not appropriately using their financial assistance policy. So I mentioned one of the organizations I have, Fiduciary Risk Management. Literally on my desk right now, 18 catastrophic claims. That's just 18 people. $82 million in billed charges. Insanity. VezaHealth side, the medical concierge, 53% of all the surgeries that we've looked at since 2017 have completely been avoided. Every spinal surgery that has come to us has not resulted in a spinal surgery. 32% of the individuals that we have touched received a change in diagnosis. As a patient, that is very scary. I'm going to talk really quickly about my own personal primary care experience. I moved from Montana to Wisconsin during this whole marriage COVID fiasco. There's not a vaccine for my marriage apparently, so I don't know what I'm going to do, but I moved from Montana to Wisconsin. In Montana, I had the same primary care doctor for a number of years, right? So I moved to Wisconsin. I do what I think is appropriate. I'm asking around who I should see for my primary care services. I don't have a DPC provider where I live. I don't have a health plan that supports anything creative and right. And I have relatives through my marriage that are doctors within the Wisconsin community. I ask them who I should see for primary care. And I narrow it down to one individual that I go see as my primary care doc. I see her for a couple years, don't have anything major going on, so it was no big deal. And then I turned 50, and it was like my wheels started coming off my bus. I should have readers, but I got kind of monovision contacts going on right now. Everything starts falling apart when I turn 50. So I go into this woman. This is more information than you guys ever cared to know about me. And I said, I just turned 50 and I am going to stop taking birth control pills. What is going to happen to me? And she looked at me straight in the face and she says, I have no idea. And I don't think you should stop taking them. And I'm like, am I really having this experience right now? And I'm like, well, I've been on them for like 30 years. I have von Willebrand's disease and there's a lot of other reasons why I've been taking them, but I've probably screwed up my system enough by now. I need to stop taking them. And now I started having migraines and my anti-vaxxer friends are telling me it's because I got the vaccine. And I'm thinking it's because I turned 50 and I don't know why, but I decided it's probably prudent to stop taking birth control pills. I just told you I went from 1 kid to 6. So I made my husband go get a vasectomy because that was not an option. That was not an option. So I said to her, maybe that's the reasons I'm having the migraines. And she's staring at her screen and she's studying it. And I'm like, what are you looking at? And she turns the screen to me and she's trying to decide in her mind whether she should give me a different form of a birth control pill, whether it's, estrogen, progesterone, or just one, or she wants me to stay on the pill for whatever reason. And so she turns her screen to me and I look at it and all of a sudden my eyes got drawn to this red X on the screen. And the red X was, if you're over 35 and you're having migraines without aura, you should not be taking estrogen, progesterone birth control pill. And so I pointed it to her and she says to me, oh, I thought that was with aura. And I excused myself from my doctor visit and I haven't been back. But as I was leaving that doctor visit, I'm driving home and I'm just really mad, right? I don't know how many people I called to bitch on the way home, but there was a lot. And I realized I've seen her for like 3 different visits. And I have a tachycardia issue, so I was on heart medicine, and that's been going on for years, and I was having some gastro stuff. And it dawned on me as I was driving home, that woman had never once even touched my skin. She never once touched my skin. And it's, when you think about the reasons that we're here, yes, we have large claims. Yes, 53% of surgeries are avoided. There are so many reasons. When Zach was speaking about His experience as a individual living in his home country, it's heartwarming to think that we could get to that point here, right? My DPC journey, by whatever name, started when I was at EBMS years ago, and we brought in a clinic, an on-site clinic for our own employees that are on our health plan to start chipping away at the issues that we continually see. I knew I was going to do this. Okay, so with VezaHealth, again, I told you we started it in 2017. I just want to give you another story that goes well with the previous speakers. Another local government school district, we implemented VezaHealth for them in the second quarter of last year. I only had 3 quarters to do something with this health plan in the 2021 plan year. In 3 quarters, we saved them $1.76 million. That's a 41-to-1 ROI, not a bad day at work. We did 19 second opinions for those individuals. One of them only needed RN support. There were 2 RSOs pending at the time this report was done. And our nurses spent on average 9.47 hours with the folks on this health plan. You can see the breakup of the employees' independence. You can see how they were referred to us. And you can see the clinical category makeup. I mentioned when I first started VezaHealth, I thought it was going to be primarily ortho. And we have a mix here of cancer, rheumatology, endocrinology, urology, neuro, and ortho. And then there were some others. This particular plan had a lot of pediatrics. So it really is a mixed bag of who we are assisting. For this particular plan, 44% of all surgeries were avoided. 89% changed their diagnosis, 57 reduced healthcare utilization, and 36 changed their diagnosis completely. There were hard dollar savings of $545,000, and I'll give you the best example from that pool of money that I can. We had an individual, remote area in Montana, diagnosed with pancreatic cancer, comes to us. We have a second opinion done. It's validated that she needs to try and have the tumor removed. Her local surgeon wanted to try and remove it. We recommended that she go somewhere else. We actually flew her to Johns Hopkins. She had her Whipple surgery by one of the top Whipple surgeons in the country. I negotiated a 30-day length of stay or episode of care, 14-day length of stay contract for her surgery that was under $70,000. Mayo would have been over $200,000. Montana would have been over $400,000, even with the contract that we have in place with the local facility, and she probably would not have lived through it. We fly her home after her procedure. She needs continued treatment, and we continue to contract and seek providers outside of the one and only hospital that's in her community that we do have a contract with. Just because we have contracts in places doesn't mean that that's the best place for us to get care for all things. It's kind of a safeguard for many clients, particularly when they live in these rural communities. And the 1.2 is risk negation. Now, I've been on the other side of a presentation, sitting at a TPA and a plan level, where somebody tells me some number that's tied to something that's a little nebulous. When we touch a patient at VezaHealth and we're done servicing that particular patient, the client gets an end of service report, and it clearly explains all the fees that we save them, whether they're hard dollar or risk negation. The reason that this one is so high is that we had one individual that went into the doctor, was told he had type 1 diabetes, was given a prescription for insulin and told to go home and come back in a year. He knew his Visa nurse from a prior incident. He wanted a second opinion. We got him a second opinion. He did not have type 1 diabetes. It is very difficult for us to determine how much we saved in plan costs and whether or not we just simply saved his life. But we know for certain that he would have had healthcare claims resulting from him taking insulin when he did not need it. I think that is all I have.
Okay, on to you, Chris.
Okay. I actually don't have slides, so I'll give that to you.
All right.
My name is Chris Deacon. I am the former director of the State Health Benefits Plan and School Employee Health Benefits Plan for the state of New Jersey. I'm actually a lawyer by training. I practiced for several years in corporate restructuring law before joining state government. That's only relevant for sort of my approach to healthcare when I eventually took over running the state health plan. I was Deputy Attorney General in the state of New Jersey for 3 years before joining the governor's office in the Christie administration post-Bridge. I just always have to say that. Post-Bridge, where I oversaw Department of Banking and Insurance and Department of Treasury. When the administrations changed over, I stayed on with the Treasurer's Office, and that's the organization that housed the state health plans. When I took over as director, we covered approximately 720,000 lives across our commercial, early retiree, and retiree populations. We represented both state employees, institutes of higher education, and then also local governments, counties, municipalities, and school districts that elected to join the plan. So we were, in a sense, competing with other carriers in the market for that business. We had approximately 70% of all local governments and municipalities that joined the plan. When I took over, we had about 25% of school districts. We had suffered some, the effects of adverse selection for several years with rising rates. By the time I left, we were up to 50% of school districts, approximately 50% of school districts in New Jersey. And happy to report that February of 2022, we actually gave the taxpayers of New Jersey, if anybody's from New Jersey, you know how important that is, a tax break by giving districts that participated in the School Employee Health Benefits Program a premium holiday for the month of February and March. We had built up such a strong reserve that we thought it was time to give some of that back. So good results. So we're here to talk about DPC, direct primary care, and what that program looked like in the state of New Jersey. I actually came to the state post, I guess, the initiative was launched. It was, in my understanding, really a mutual sort of push from labor. I should add that the state employee health benefits program and school programs are governed by somewhat political bodies, I would say, equal part labor and management. There's nothing like getting stuff done to have equal part labor and management on a board to really make swift decisions. But anyway, this is something I think that all sides could really get on board with, right? Direct primary care. We knew that we wanted to invest more in primary care. We knew that we had a supply chain problem in terms of medical spend, like no ability to have insight or transparency into sort of that downstream cost. So, direct primary care was really seen as a way not only to invest in primary care, which we know we needed to reinvest in, but also to begin to have some influence on the downstream cost and the supply chain of healthcare. The program officially launched in 2017 with an RFP. We partnered with two initially DPC providers in the state. I believe at this point there are 14 direct primary care clinics across the state. Everside is the current partner, Everside and Sanitas. I believe they're looking to expand. I should have added too, I left the state in September of 21. A topic for another day. You'll probably read about it at some point. But the program is really doing well and growing. I think that one of, we could talk all day about, the contracting process and why DPC came to be, this initiative with the state of New Jersey. But what would be most valuable to you sitting in this audience is really the lessons learned, because we were one of the first state employee health benefits plans, and certainly the only state health benefit plan of our size, to engage in such a pilot in a program. So I think number one, when it comes to contracting with a plan, you have to get the contract right with both your DPC provider, but even as important is with your TPA or your carrier, right? So in order to be successful, in order for you to enable your DPC partner to be successful, you need to share data. You need to share good contact information. You need to have a carrier or a TPA that is willing to partner with you and enable the DPC to be successful. I start with that because I think it's the most important. I think there are a lot of, I think you mentioned some regulatory hurdles, legal hurdles for, sort of the broad adoption and implementation of DPC. I see one of the biggest hurdles, and I certainly experienced this, is that status quo legacy player carrier standing in the way of data sharing that's going to enable success. And really their willingness to sort of play nice in the sandbox and effectuate and implement an employer's priorities. They very much see direct primary care and the model and the journey that we're going on in direct primary care as a threat to their well-being and their value proposition that they bring to clients. And I say value proposition in sort of air quotes because the value proposition of the big BUCA carriers in today's world is really in limbo. I think we can all agree with that, with the way that transparency is heading. And, I think that's why, quite frankly, there is sort of this willingness or lack of willingness, I should say, to enable DPC. Why is that? I think, again, it's important to point out that through DPC and advanced primary care, you have a real ability to impact downstream costs and have transparency into the quality of providers, whether it's through second medical opinions or I'm not going to say a narrow network, but a curated network of high quality, efficient providers in the downstream, supply chain of medical costs that might get you to a hospital that's not going to charge 500% of CMS, where you have just as good a provider down the street, charging 175. When you reduce the overall total cost of care in healthcare, the carriers lose, right? So I think it's just calling a spade a spade. They stand to lose something here. So you have to protect yourselves contractually. And this is, again, from a health plan perspective. And if you're a DPC provider, how do you counsel your employer sponsors to enable you to be successful? Both of those contracts have to be right. From a DPC perspective, you have to make sure you're aligned, like your financial incentives are completely aligned with your employer sponsor. What do I mean when I say that? I mean that your financial contracts and arrangements that are in place can't motivate you solely to sign somebody up on a registration at an open enrollment fair and never touch or see them again, and then fall off the capitation rolls 12 months later. Right? There have to be mechanisms in place where it's in the employer's best interest to drive as many people to your doors as possible. And on the flip side, in your best interest for the employer to do that. And how that financial alignment looks in a contract is really important. Finally, I would say leverage your labor partners, whether that's an association or a formal labor union. Obviously, there are certain states and locations that are more labor, organized than others. Labor's having a moment too, by the way. Bring them to the table, even if it's not in a formal capacity, because the only other player that members trust more than their primary care provider, and I apologize, I don't trust, or hope that you don't trust yours or your former one. But, I think the Kaiser Family Foundation survey found that, I think 85% of members trust their providers, and then you get down into the teens and 20s for healthcare insurance companies and maybe a little bit more for your employer-sponsored health plan. But you have to leverage that trust, and labor gets that. So and your members are going to trust, to the extent that they have labor partners, that as a really unbiased source of information. So engage in those partners. Don't view it as a management only and a cost savings first. Mm-hmm. View it as a quality first, and also an investment in workforce capital. I think in today's labor market, that's a really important thing to think about. Like, how do you distinguish yourself as an employer? So focus on that as well. And then finally, I would say, be willing, and this is for plan sponsors or DPC providers, be like willing and able to customize to the populations you're serving. So just by way of example, we represented all first responders in the state. So state troopers, family and children's services workers, and frontline workers who were experiencing trauma on a daily basis. We have a first responder primary care medical home that is designed, everything from plan design to the actual layout of the clinic, that is designed for first responders that have been exposed to trauma. So we have mental health services, we have PT chiro and acupuncture, and it's all designed in a manner so that when you have, a cop who might not necessarily be comfortable seeking mental health services, when they walk into that clinic and go through those doors, nobody knows what they're going to see. They could be seeing, going to the pharmacy to pick up their generic medication. They could be going to a family therapist, or they could be going to a PT. Our teachers, we have, very specific designs around our teachers. So again, be willing to customize, because the key to DPC is that it's bringing medicine and the practice of medicine back to where it started and where it should be. And that's personal, local, and relational. So never lose sight of that in sort of the pretty clinics. I think, that I want to make sure we have time for questions, and I'm looking at time. Finally, last parting note, and hopefully that there will be some questions or catch me afterwards. I think that direct primary care as an employer and an employer purchaser fits right in such a neat and buttoned up way to this new fiduciary landscape that we find ourselves in as employer sponsors and fiduciaries. No longer are we able to sort of trust the PPO and, everybody, all the vendors out there to do our sort of bidding and judging for us when it comes to cost and quality. The onus is now on us, and the Supreme Court has certainly signaled that in the recent Northwestern Mutual case. And again, catch me after if you want to talk more about it. But in essence, we've been tasked as health plan sponsors and fiduciaries as to not only make plan options and quality providers and affordable providers, sort of accessible as a choice. We've really been tasked with looking and judging and on an ongoing basis, monitoring what providers and what contracts we're putting in front of our members from both a cost and quality perspective. So I think we really need to take that moment and see DPC as a real solution to that risk mitigation problem. Thanks.
Thank you, Chris. We've got about 12 minutes left, and again, at risk of putting the lawyers in the slot right before lunch, we're going to try to stay on time and leave a little time for some Q&A, but a few remarks just to kind of button up what you've heard. I think it's important to take a step back and consider what is the role of the law and of legal policy in a free market. And a free market is not anarchy. It's important to remember that. In order for a free market to function, you need an orderly mechanism whereby people can contract and property rights are enforced. And only in those circumstances, when you have good underpinnings of law, can a true free market emerge and prosper. And we look at countries around the world that don't have those things, that are more either anarchic or totalitarian, and you don't see free markets. You don't see the magic that free markets can bring to bear for individuals, consumers, and citizens. So what is the role of law in a free market? It's to really set the rules by which prosperity can emerge, and then to get out of the way. And it's funny, a lot of times we'll get policymakers that reach out and say, what can we do? What can we do at the federal or state level? And the first answer is always do no harm.
Yeah.
All right? Do no harm. Ideally, what we're talking about in many ways when it comes to legal policy is removing barriers. Because in a free market, when you have a voluntary exchange of goods and services between willing individuals, you see supply meets demand, there's an equilibrium, pricing is transparent, value is almost inevitably rising for participants on both sides of that coin. So looking at the free market in terms of medicine and healthcare, one of the goals we all in this room are promoting is this expansion of a free market system, of an ecosystem. And that means both increasing the demand for free market healthcare and the supply. The one thing, and I guess in our country we have the dichotomy of a federal level regulatory and legal regime and a state level regime. And at this point, yeah, it'd be great if at the federal level we could see some progress. And I know it's funny, I heard 3 times that this is a bipartisan issue. And our experience was the same way when we worked with the DPC enabling legislation in Indiana. This is a bipartisan issue, one of the few today that the parties can agree on. It would be great to see the federal level, if nothing else, level the playing field for DPC practices as compared to conventional or insurance-based practices. That could be a tweak to the tax code, it could be legislation. But until we achieve a breakthrough, I think the state level might be more fertile ground for activity. And so in addition to the DPC enabling legislation, one thing that we're seeing right now that is really helping to unlock the supply side, helping to liberate more doctors, and has the potential to do a lot more, is to reform something, and I'm going to go into a different area of the law here, this is employment law, but to reform the way that non-competes are enforced. And in Freedom Healthworks, we see, there are 3 major barriers to physicians moving to this model, physicians who would like to move to the model, right? It's the transition risk that we have to overcome. It's the operational risk within the practice itself, kind of day 2 risk. And it's the economic risk, if nobody shows up. You overcome those 3 objections, and there are a lot more doctors out there that would love to do this. And that supply increases, which then fosters additional receptacles for the demand that a lot of you are driving in terms of plans and patients and employers. Non-competes are a tremendous barrier to that first goal. These are anarchic, and I think we've seen some progress. I know in Indiana locally, we've had non-compete reform for a couple years. They're pushing again to try to codify things like buyouts and arbitration to establish those. I think there's a different approach, and I just want to throw this out there to get some wheels turning at the state level. I know Texas is very active on this front. Florida is about to get very active on this front. But a little bit of law here. A non-compete exists for very narrow reasons. It's to protect an interest of an employer from, in 3 ways really, right? They're limited by 3 things: time, geography, and scope. And so in terms of time, all non-competes have an expiration date, right? They all have geographic limitations. You can't say, thou shalt not practice anywhere in the country. And they have scope limitations. And these have been enforced by courts. Doctors who have left with a non-compete, a primary care position, a family practice, have gone on and successfully been able to practice, say, emergency medicine, because courts say, look, that is not competitive with what you were doing before. You're not harming your employer by doing that. Again, the reason I'm going down this path with something that is really employment law is the fact that this is something we can affect now. Maybe at some point we get traction on the federal level. We've continued to see success with DPC legislation state by state to say this is not insurance, don't regulate it as such. But this is another frontier that we can make progress, and it will have tremendous impact on the number of physicians who would like to migrate to this model. So for those of you listening, again, I don't want to go too far into the weeds, but the notion that it's a good analogy is, and we rented a car at the airport. Show of hands, how many people think that Budget Rent-A-Car is in competition with Ford Motor Company? Why not? They both provide automobiles, right, to consumers. They both provide automobiles to consumers. Why are they not in competition? It's an analogy that is similar to trying to say that an individual direct primary care doctor is competing with the mega hospital across the street. Yeah. Right? Completely different business model. And why I think that legislation is necessary there, you have these completely disparate players, right? Very different war chests if they would go to court. In many instances, simply going to the mat, even with a really good legal case, is a loss for an individual doctor. you're not going to outspend the $1 billion not-for-profit across the street, right? The hospital. So I think we need legislation at a state level, because that's where non-compete contracts are regulated, that codifies this and says, practice of medicine is too vague of a prohibition. Why don't we talk about limiting the practice of medicine to real competition? That still lets the hospital say, well, I don't want one doctor jumping ship to another hospital, but you can't use a non-compete to lock somebody into employment. I don't care how hard they are to recruit and locate and train. That is an improper use of a non-compete. Again, if you're listening out there and you're a policymaker and you want to talk about this on the state level, I think that's fertile ground to make some real progress. So,
quick, Jay, with you and Phil Eskew, as you guys went state by state, were there things that could cross-pollinate with what Adam's talking about now?
To be honest, we made a really vociferous effort to keep these as standalone pieces of legislation, because they weren't easy. I was in Virginia, 2 sessions in a row. We had in Virginia, we had a coalition of doctors and hospitals and employers and religious groups and patient advocates and everybody against one adversary, Blue Cross. And we passed the bill unanimously in the democratically controlled Senate. And then, as a little anecdote, as I'm walking out of the Capitol after we passed the bill, the Blue Cross lobbyist walks up and says, "Oh, we're not worried about that. We'll just get the governor to veto it." Mm-hmm. Unanimous. I think maybe the House, there were 1 or 2 objections. The governor vetoed it. So we were up against some pretty powerful forces. So on a lot of the state legislation, it was better for us to keep it narrow. But as you saw the map, we're not done yet. We're working in Alaska on a bill right now. Wisconsin has been working on a bill. There's some places where there's some black letter law that just needs to be changed. But, I think it's time to begin to expand, our book of things. I think, in Texas, we've got to do something about the dispensing situation, and in a couple of other states as well. There's a number of things that I think are next on the plate. But for us, job one was to make sure what we were doing was legal. End of story. So I think we're into a transition on that. And the best thing that we have, the best arrows in our quivers are exactly what Chris is talking about, the data. You've seen 3 people up here present that they've reduced total cost of care by improving care for patients and reduced that cost of care for employers by about 20%. We have fairly consistent data. There's a Milliman study out there from a couple of years ago that you've probably all seen that shows this. So if we can take this data back to people and use it not only to help grow practices, but to help influence, where laws are getting in the way of expanding the supply chain, as this clearly is, that's what people want to see. All right, we let you do what you were going to do a couple of years ago. Now show us the results. And there's nothing wrong with that. You all have an amazing story to tell, DPC doctors and employers that have gone down that road about how well this works. We got to show it. And I agree. We need to expand into some other areas.